All right. Hi, everyone. My name is Zachary Hudson. I'm a student physical therapist working with the Olympic Medical Center rehab team. And today we'll be talking about early joint mobility and early mobility after joint replacements. Get this all set up for presentation. So the goal of this presentation is to talk about the benefits of early mobility, as well as kind of discussing some goals that we have for communication and interpersonal collaboration between nurses and physical therapists specifically. Looking at some of the objectives, we want to understand the role of early mobility in post-op recovery, as well as recognizing key contributions that nurses provide into the safe and early mobilization of these patients, identifying common barriers to patient mobility, and improving interprofessional collaboration between nursing, PT, and occupational therapy to optimize patient recovery. So before we really jump in, we're going to talk about why early mobility matters. There's been a ton of research delved into this topic and has found a bunch of different things that are super beneficial for patients with mobility. Generally, early mobility has been proven to help prevent post-surgical complications including DVTs, pneumonia, pressure injuries, edema, and a bunch of other stuff. Those are just some of the more common ones, to name a few. It has shown to be effective in reducing long-term pain and stiffness in patients with joint and knee replacements. It helps promote circulation and healing in these joints and after surgical interventions. It improves functional independence, as well as shortens hospital length of stay and has a really added benefit of reducing general costs for patients. One program that I found, and one thing that I really liked and wanted to include here, is this program called Enhanced Recovery After Surgery, or ERAS. It is an evidence-based practice that gives a bunch of recommendations on improving surgical outcomes. They generally break down ERAS into a bunch of different preoperative, intraoperative, and postoperative sections. For the focus of physical therapy and nursing specifically, we'll look into the focus of postoperative goals. So ERAS has a bunch of different protocols that talk about how to promote the best options and outcomes for patients with surgery, but they really do support early mobility, even within the first hours of surgery. They talk about the benefits of multimodal pain management and nausea control, the removal of catheters as soon as possible after a patient is out of surgery, as well as early mobilization up to 2 hours within the first day of surgery and up to 6 hours within the second day of surgery. That's not to be saying that we have to mobilize patients up to 2 hours or a maximum of 2 hours each day, but that up to that level has been having shown benefits for these patients. So if we don't get them up and moving 2 hours in the first day, that's okay. So let's break down some numbers for some patients that have been mobilized within the first 24 hours after surgery. Generally, patients with knee replacements that were mobilized within 24 hours had a 20 to 30% shorter length of stay in the hospital and were able to discharge much more safely. They had general reports of decreased pain and improved range of motion with all tasks, which is something that we as physical therapists look at very specifically and very heavily. They have a lower likelihood for short-term and long-term complications. One study that I found discussed the fact that patients who mobilized were almost 3 times more likely to suffer a DVT if they were not mobilized specifically within 24 hours. Also, in general, patients that get up and move within 24 hours have an overall higher satisfaction with their surgeries and their overall recovery rate. So, looking at more focused onto Olympic Medical Center and some patients that you might see here in rehab and everything else that we're working with. We have a few different joint replacements, and these are going to be the joint replacements that I'm going to be focusing on for the rest of this presentation. You have joint replacements like total knee replacements and total hip replacements. Both of these replacements come with their own types of precautions and expectations for mobility. Generally, when looking at a total knee replacement, they have what's called weight bearing as tolerated. Now everything in this can vary to some extent, but more often than not, you will see these patients having weight bearing as tolerated precautions. When looking at a hip, they generally have posterior hip precautions depending on the surgical approach. They also generally follow the weight bearing as tolerated category when moving. Again, very case dependent, things can change from patient to patient. One other area that is common to see with hip replacements is specific movements like leg abduction. This can really depend on complications during the surgery, complications before the surgery. If a patient had a greater trochanteric fracture, they might not want to be moving that leg into abduction to help allow that fracture to heal as well. Additionally, if a patient falls and has muscle tears or other traumatic injuries that follow that hip replacement, they might need to be restricted on certain movements as well. This little handout that we have here is something that every patient gets with their preoperative packet, as well as something that physical therapy brings in. It helps break down a few of the precautions and the posterior hip precautions specifically that patients have. These precautions are very important to follow because if these patients don't abide by these precautions, there can be additional complications. So our first precaution is the flexion precaution. We don't want to be breaking 90 degrees of hip flexion. So patients trying to bend down to grab something or maybe put on their sock while sitting at the edge of the bed, we really got to avoid that with these patients. Abducting precautions, adducting precautions involve crossing the affected or surgical leg over the unaffected leg. That's another precaution we want to avoid, as well as internal rotation precautions. This can involve anything of bringing the knee and pointing the knee inward. Going pigeon-toed is often a term used, where you point the toe inward and twist the knee in. Those are all precautions that we want to avoid. And this handout helps reinforce that with patients. There's also some other factors to consider when working with these patients after surgery. And one of the other big factors that we as physical therapists look at is general versus spinal anesthesia. So I did a bunch of research in trying to find different studies and different topics that talk about the differences and the drawbacks and the benefits to general versus spinal anesthesia. Unfortunately, most studies had a pretty hard time finding differences between the two types, and that largely a lot of these studies identified that it was very case dependent. Every patient metabolizes anesthesia at a different rate. Anesthesia affects patients differently. So it's always worth it to keep in mind that it does depend on the patient. One study that I thought was worth involving, and a few studies I thought were worth involving here, was that one study found that general anesthesia often takes longer in surgical time. So just keeping that in mind, that patients who go under on general anesthesia might take longer to come out of surgery than those with spinal anesthesia. Looking at spinal anesthesia specifically, one of the most common recurring observations was that patients would have incontinence after spinal anesthesia, and that's a very common one. And we want to focus on that and emphasize that here because, as we'll get into later, incontinence is a really big thing that we look for with physical therapy. They're less likely to be nauseous with spinal anesthesia, and some studies found a shorter length of stay. Again, there's a lot of other comorbidities and factors that influence that length of stay time, but for right now, that was what one study found. Additionally, looking at the type of surgery, the anesthesia they underwent, we also can kind of get a better grasp of what the different types of plans are for these patients when they come to the hospital. So we have generally two different types of hip replacement patients. We have same-day patients and overnight patients or extended length hospital stay patients. The big thing that we as physical therapists want to emphasize to everybody is that it's really important that both of these patients, if they're staying overnight or if they're leaving that same day, get mobilized the day of after their surgery or the day that their surgery occurred. For looking at same-day discharge, we wanted to kind of give you a perspective on what physical therapy looks for and what we expect when working with these patients. Generally, orders for physical therapy will come in earlier with same-day patients. Patients who are qualified for same day often have better tolerances to activity. They have less comorbidities, things like that. PT will have planned to have seen patients by this time because they are going to be leaving very soon, and we want to make sure we can get in there and evaluate them before they leave to make sure there's no other concerns. When looking at overnight stay patients, orders might come in for physical therapy a little bit later in the day, so we might not always be able to get to these patients. Patients generally have other comorbidities or reasons for staying overnight. PT will see these patients if they're ready, and that's going to be a big emphasis here on if they're ready, and we'll talk about that more as well as we continue on. One thing that I really want to emphasize here, and kind of with the statement at the very top, is that if PT does not evaluate the patient that day, nursing should still be mobilizing this patient when it's appropriate on the day of surgery. And that's just something that, again, we want to be making sure these patients are mobilized every single day, and especially immediately following their surgeries. So the goal of this presentation is to really help give a perspective on physical therapy, as well as providing some options and ways to improve interprofessional coordination and improving patient mobility and care for patients between nurses, PTs, everybody in the hospital. So when looking at a nurse's role in mobility after surgery, there's a bunch of things they do. And this list is by no means all conclusive and covers everything. I just included what we as physical therapists often interact with and how we are able to see these interactions. So generally, nurses are involved in encouraging and reassuring patients about their expected mobility level. Most patients are ambulatory the same day of their surgery, and this is something to really keep in mind while you're talking to these patients, because many patients will not be aware that they should be ambulating the same day as their surgery. Again, they're more often than not, they're going to have a precaution called weight bearing as tolerated. So the surgeons generally feel comfortable that it's up to the patient to see how much they can tolerate with movement. The surgeon's not going to be as worried about them injuring themselves or anything like that as long as that precaution and other precautions are maintained. Nurses also are responsible for monitoring vitals and making sure that patients are safe while they're moving, as well as assessing and communicating about their patient's current status to other healthcare professionals, whether that be some examples include sensation, bladder function, strength, surgery site integrity, and additional post-surgical complications that might be worth noting or discussing with other healthcare providers. The other thing that's really important for nursing to be aware of when getting ready to mobilize patients is reinforcing and educating patients on hip and knee precautions, making sure that they're aware of everything that they can and cannot do on a day-to-day basis. So, emphasizing some collaboration here on nursing and PT working together to really improve patient progress and rehab. Clear communication, everybody's going to hear about. Everything is important, and clear communication is the first line. And understanding each other's goals is going to help substantially in making sure that we can communicate clearly and understand where everybody is and what everybody needs to do their job effectively. Nursing staff is constantly interacting with patients, and that's why PT will often check in with nursing to see if patients have had any changes or any concerns when considering therapy for them. Nurses reinforce mobility throughout the day before and after PT, and that's important to keep in mind because PT often only visits once a day. PT generally gives nurses a recap about mobility and what they've found and the kind of goals that they want to focus on with these patients, but it's really important to emphasize that before and after with physical therapy. Nursing also can notify physical therapy when joint replacements are ready and ready for their evaluation, and that's kind of what we're going to dive into and focus on more here. But again, really emphasizing that clear communication with everything that we do. To give you kind of a better perspective on what physical therapy does with these joint, hip, and knee replacements, generally, the first things physical therapy will look for is lower extremity sensation, looking to see if the patients still have any numbness from that anesthesia, looking mainly at the feet, the knees, the hips, and the buttocks, just to see if the patient is still numb. Because if a patient's still numb, generally we'll wait to do an evaluation until later on in the day when they have more of their sensation intact. Physical therapy will also look at joint range of motion and lower extremity strength. They'll assess patients' level of assist required for generally all mobility that they would do throughout the day. We also just get a better understanding of what their general tolerance to activity is, and if they're able to complete their ADLs, as well as some rehab exercises that we'll kind of show in the next slide here. Also looking at just what the patient's likelihood of DCing home or where they need to DC, and if they're able to walk the distance that they would need to walk while they're at home, if they would need to go up and down stairs if they have stairs at home. That one's more case dependent, as well as just other general mobility tasks. So this is a list of some of the exercises that we would bring in, or the exercises that we would bring in for patients after a knee replacement and after a hip replacement. The big thing to note here is that these patients generally will have these handouts in their preoperative packets. And we have also really observed a really big positive outcome in patients who are doing these exercises before surgery as well. There's a bunch of research to back that up. ERAS talks about that a lot, where they say that getting preoperative activity going beforehand to prep these patients for surgery has a ton of benefits on their post-surgical recovery. But just to show kind of what activities these patients are expected to do right after surgery, we have things like the heel slides where we're getting that knee bent, we have some straight leg raises, we have a bunch of muscle activation right off the bat, and that's why it's important to make sure that these patients have sensation. So why is it important to mobilize and screen patients before physical therapy? So this is where we want to really talk about the fact that patients are not at their baseline when they come out of surgery, and PT only has one evaluation. This evaluation is often used to identify major concerns with patient progress and looking at discharge options. So if a patient is not quite ready for surgery or quite ready for physical activity and they're coming out of surgery, the evaluations can tend to be skewed. If they have some numbness or loss of sensation in that lower extremity, they might be more or less tolerant to activity than they would in the next few hours after that anesthesia has worn off more. If they're unable to support themselves due to loss of sensation or muscle control, that can also have really negative additional complications and side effects. One thing, and probably one of the biggest things outside of sensation that physical therapy looks for, is incontinence. If a patient is incontinent, we're not going to be able to get them up and walking the halls and taking them on stairs and stuff like that, because we need to keep them close to the bed and honestly move them back into bed. So if a patient is incontinent, PT is postponed until bladder control is returned. One big note here and one emphasis that we've observed with patients that have had these surgeries done is they might report that their sensation is intact but still be incontinent. They might have full sensation in the hips, the buttocks, the knees, all of that, but they still might be incontinent. As well as if they have anything else like lower extremity buckling, there can be a bunch of different causes for that, whether it be pain, numbness, control, anything like that. And these bucklings, all of this additional complications can involve breaking precautions. So we really want to make sure that these patients have been screened for mobility and are able to tolerate some level of mobility before physical therapy starts their evaluation with them. Ooh, let's go back up one. So let's talk about some common symptoms that we will see after surgery with these patients and things to expect when you're working with these patients. The biggest complication that we expect to see is pain. That's the primary concern that a lot of patients have, is pain after a surgery like this. Often patients will also report a decrease in trust in their joint or their leg. This has a bunch of different causes and a bunch of different reasons. Some of them can be due to prior level of function before the surgery, as well as maybe having a loss of sensation or control after the surgery. Again, anesthesia can really affect these patients. Patients can also just feel anxious about putting weight on the joint. They might be concerned that they're going to re-injure it or damage the surgical site. So that's why it's important to educate them. Looking at bleeding, there is always an expected amount of bleeding that is going to occur with surgeries. And it's often reported in post-operative notes about how much blood has been expected to be lost while in the surgery. And anemia is, one study found, anemia is one of the most common side effects of post-surgical joints replacements like this. The patients will often be low in blood levels. You'll also see edema or swelling in joints, knees and hips and stuff like that. You'll have patients reporting lightheadedness, nausea, and fatigue as well. Those all kind of go hand in hand with a bunch of different factors that are influencing it. Looking at barriers to early mobility, I broke this down into two different categories, mainly looking at the hospital and the patient. So looking at the hospital, some of the bigger barriers that most hospitals report are staffing and time constraints when trying to mobilize a patient. If there's just not the available time for it, it doesn't tend to happen. There's also a generally often reported a lack of confidence in safety and handling with mobility techniques for these patients, and we're going to kind of break down some good ways to approach that in the next few slides. On the patient end for barriers to mobility, it's going to be a lot of those signs and symptoms we talked about earlier. It's going to be pain. If they weren't super active beforehand, or if their prior level of function didn't involve using that affected limb very often, they might not want to move. If they're concerned about putting weight or using the limbs to help them, if they've been uneducated about mobility goals and expectations, again, talking about how patients are up and moving the same day as they came out of surgery. Nausea is often a very large barrier for patients coming out of surgery, that they don't want to get up and move if they're feeling sick, and that's very understandable. As well as just general activity tolerance. That can be kind of a more blanket term to cover pain, to cover prior level of function and stuff like that. If a patient isn't very tolerant to activity, they're not going to want to get up and do it very often. So, with those barriers in mind, let's talk about some strategies to overcome them. Some of these are influenced by the ERAS protocols. ERAS tends to talk about the use of multimodal pain management. We use the on-cues here. We use pain medication here to help kind of work with patients on that pain, because again, pain is probably one of the biggest limiters that you're going to see. Looking at intravenous fluids, these patients have lost some blood. They've been on diets. They haven't been able to drink as much water as they want to. So they're probably pretty low in those levels. So being able to get some fluids in their system is going to be really important. Providing a small amount of food post-surgically within patient comfort has shown to have early signs of improving bowel function and returning bowel function. One study found that just giving a patient gum, something that they won't even chew and swallow, they simply just chew on, has shown improvements in return of bowel and bladder function right after a surgery versus not chewing on anything. So if a patient, for whatever reason, is incontinent or anything like that, sometimes it's good to consider food or gum. If we're concerned about mobilizing the patient and getting them up, and that, we might not feel super confident in how to move these patients, we can break down the mobility into smaller steps. This is really important because it does two things. It helps improve patient confidence in their mobility, as well as improve care provider confidence in mobilizing these patients. The rehab team has made a really awesome mobility screen handout that we'll address in the next slide that kind of helps break down those steps into more digestible, more common practiced strategies. The big thing that I also want to emphasize here about mobilizing and getting these patients up step by step is that for screening for pre-PT mobility, one of the biggest stages that we as physical therapists want to hear of is if the patient was able to stand up or not. Standing has a bunch of different supporting evidence and supporting factors that help us identify if we are ready for physical therapy, if a patient is ready for physical therapy or not. If they stand up, it often confirms that they can bear weight through the leg. It often confirms that they are strong enough to hold themselves up or not. It often confirms if they have incontinence still. That's one of our big ones. Again, if a patient is incontinent, we would tend to hold PT until they're no longer incontinent. Using assisted devices is another really good strategy in overcoming some of these barriers. We don't expect patients to be getting up by themselves with no help on the first try. So we generally bring in walkers to help mobilize them and give them some support, letting their arms help them out where their legs can't make up for the difference. As well as just generally encouraging team communication. Feel free to reach out to the PT or OT or any other rehab members in OMC. If you have any concerns about mobility, let us know if there's anything that you're worried about or that you don't feel comfortable with doing, because we are more than willing to help. And that's what this handout is for. So this mobility handout, while not directly targeting joint replacements, is really good at breaking down just general patient mobility and can perfectly be used for joint replacements. So we kind of have our different categories here, breaking it down into bed mobility, into sitting balance, sit to stand balance, standing balance, and then stepping in place, and then finally walking away from the bed. So the center column here breaks down, are there any concerns you have about this? Is the patient able to manage certain things? And then depending on your answer, you can look at what is needed for the patient in the far right column. And again, we would really love to see patients getting to that section 3, section 4 at least, before considering them for physical therapy. Because if we can get them to stand up, we can really rule out a lot of our different concerns or problems when it comes to going to physical therapy. So I've provided a few cases here to kind of just give a little bit more of a real world example to what we would be doing with these patients and what we would love to see happen with these patients before physical therapy. So these cases are discussions and are focused around relevant information that physical therapy needs prior to evaluations. They are not all inclusive for information and for all healthcare providers, and they do not cover all areas of everything else that a patient is needed throughout the day, simply focused on more of what physical therapy looks for. So our first case example is a 68-year-old with a left total knee replacement. They have a BMI of 24. They've had an estimated blood loss of 400 cc's. The prior level of function, they say, was pretty active. They were out doing stuff. They were doing hikes pretty frequently. They were active. Their only precaution that they have is weight bearing is tolerated in that left lower extremity. So let's take a look here and see if this patient is ready for physical therapy or not. First thing to look for, do they have sensation? Is their sensation intact? You check to see, can they feel their legs? Is there any numbness, tingling, anything like that? If they feel everything and they don't have any reports of numbness or tingling, I think we're good to move on to the next step. Let's get that patient sitting up. So again, following those kind of slow sit up at the edge of the bed, can they balance themselves? Are they feeling okay? They report no nausea, but maybe a little bit of lightheadedness. So we kind of wait for a second, see if that lightheadedness subsides or if it gets worse. If it subsides, we move on. All right, we're looking at standing the patient up. We're getting them ready to stand up. This patient's ready. They're motivated to do so. We give them a walker just to give them a little bit more support. And the patient goes to stand up, but they're a little bit weak and painful. But with the use of the assistive device, they can stand up independently. While they're standing, we have no observed incontinence. They're able to march in place, things like that are great. Okay, let's ambulate them to the bathroom. The patient can get up, they can walk to the bathroom, they can walk to where they need to, and then they can return to bed or return to a chair. At this point, I think it's a great idea to notify PT that this patient is ready for an evaluation. They've checked off all the boxes for mobility and they're ready to go. I have another case example here. So kind of following the same concept here, a 74-year-old with a left total hip replacement. They have a BMI of 30, an estimated blood loss of 250 cc's. Their prior level of function, they were a little bit less active than they would like to be, just mainly due to that hip pain. They just weren't really able to be as active as they wanted to be. Their precautions are weight bearing is tolerated in that left lower extremity, as well as some posterior hip precautions. So with this patient, when considering the hip replacement and the additional precautions that they have, we got to make sure before we mobilize or do anything with the patient that they know their precautions. So check in, make sure that they know not to bend past 90 degrees at the hips, not to cross their affected leg over their unaffected leg, and not to let that toe or knee dip in, pointing inside in the middle. Okay, they know all that. We can move on to the next step. Looking at sensation, do they have any sensation issues? Are they concerned about anything? Do they feel their legs? Is there any numbness, any tingling? No? Okay, we're good to move on. All right, get the patient sitting up at the edge of the bed. They need some encouragement. Again, they're a little bit cautious about sitting up and moving. They feel like they should probably just be holding still and letting that body heal. But we encourage them. We talk to them about the level of mobility expected for them at this time and that it's normal to be moving around after surgery like this. So we break down that mobility. We get them sitting up. We get them balanced, and then we scoot them over to the edge of the bed. They're feeling fine once they sit up. They have no nausea or lightheadedness to report. So we move to standing the patient up. All right, we get the walker out. They're starting to feel more confident as they stand up. We use the walker to help support them as they stand up, but unfortunately, they're still incontinent. They don't quite have control of their bladder yet, and they're unable to really move away from the bed. So at this time, we're going to consider sitting the patient back down and letting them continue to let that anesthesia wear off before we continue. And at this time, we'll notify physical therapy that the patient is still incontinent, but has their sensation intact, and they might need a little bit more time before they're ready. So again, these are just some more basic goals or basic cases. These do not cover everything. They do not address every aspect of it, but just for a thought process of what we want to see going through and mobilizing these patients before physical therapy. My general key takeaways for this presentation talk about the benefits of early mobility and the recovery and the faster recovery that it has, as well as the fact that early mobility improves and reduces post-operative complications. We want to acknowledge the role that nurses play in mobilizing mobility, as well as reinforcing just confidence in physical activity before and after physical therapy. And that just that cooperation between PT and nursing can really lead to the best patient care and the best patient outcomes in the hospital setting. And that for these patients, especially in the first 24 to 48 hours, every step counts. It's very important to keep them moving. If you have any questions or concerns or anything that you want to discuss further, feel free to reach out to our OMC rehab team. They will be more than happy to talk to you about anything and anything that we have. We have these handouts all over the place. We can give them to you if you don't have one. And thank you so much for your collaboration.